Okay, thank you again for agreeing to be on our panel. I think for me, the first question cuts across everybody. Why do you think we should involve the private sector, leverage on the private sector? As much as possible, use the example of the work that you do, to provide answers to that.
In the Lancet Commission article, which I recommend for everyone to read, it mentioned that there are more people dying from the quality of care in the facilities they visit as compared with those who haven't even accessed care. So this is the reason why when I had comments about how do we get the women there, does she have the money to go there, all that is important. But research has shown that the quality of care in the facilities is actually a bigger cause of death. And so that's the reason why we lean into the quality of care in the facilities, and it's important to begin to look at what is going on, particularly in the private sector, which is the focus of this panel. Maybe as we proceed, I will speak more about what I know about that.
Okay, thank you so much about that. I will go to the next lady because, I'm a feminist. Yeah. I have more colleagues as women in the office. I have 2 daughters, so you can imagine. Okay, Abiola, why is Access Bank interested in health?
Okay, so from the broader perspective, I think last year government budgeted about just 3% of the annual revenue to healthcare. So that means that the rest of us, we need to manage whatever percentage is left, like you rightly said. And I know that now organizations are getting to the level where nobody's caring about the size of your balance sheet anymore. You can be the biggest in terms of customer-based assets, but organizations are beginning to look at the impact that they're contributing to the community. So it's not about being the largest or the biggest, which, of course, we can say we are the largest bank in Nigeria. Yeah. But we're also looking at how can we impact our environment sustainably in such a way that we're balancing both the financial prosperity and the prosperity of the people. So that is what is in it for us.
Okay. Olamide, why, should you leverage on the private sector, and what's Farmer Access Foundation doing about that?
Thank you very much. We're all very passionate about trying to facilitate quality healthcare services. And I think that until we begin to look at these issues in a holistic manner rather than in isolations and us coming together, because we have different people that sort of like look at these issues, and then they're working at par and, it's not working too well. So I just want us to look at it. So from a political perspective, we look at the allocation of healthcare, from government over the last 10 years. It's been about between 3 to 5%. And then we also look at the performance of that allocation. It's also not been too great. As a country, Nigeria is not doing too well. I read in the papers recently that Nigeria's revenue to GDP ratio is about 7%. So in terms of the government being able to allocate enough funding to provide quality healthcare, it's not because they don't want to or because they don't feel the same way we feel. It's because they can't. The fiscal space available for government to do this is very limited, and so they are sort of handcuffed in being able to deliver on the mandate that they should. From an economical perspective, you mentioned it. You look at the total healthcare expenditure of the country, and one of the things that really bothers me is when we talk about this $1 billion of medical tourism, and nobody's looking at the 2.75 trillion that is floating around in our system. And how can we, as a people, look at harnessing that fund through financial inclusion policies, through remittances? Look at remittance now, the amount of funding that comes from outside the country into the country. It's about 28 billion. Which is 83% of our budget and 11 times foreign direct investments. How can we harness this money? Because there's a lot of money in private sector. You look at the growth GDP of Lagos State. GDP of Lagos State is $131 billion in 2018. What Lagos State made as a state was 301 billion naira in terms of the monies available within that economic space. So that's another angle of why we need to include the private sector in terms of the financial viability of the private sector. We then look at the cultural aspect. You look at the percentage of people that go to a private facility or a public facility. Of course, a lot of people know that majority of people prefer going to a private facility. And why? Because of, supposed efficiency and ability to get quality healthcare. the assumption is also that the majority of people that go to a private facility are the rich. But studies have shown that 40% of those that visit private facilities live in Q1 or are Q1, Q2 people. So even the poorest of the poor identify that the private sector is more veritable in terms of delivering quality services than the public sector.
From the work that you do, to what extent do you guys, leverage on the private sector?
So we focus mostly on the private sector engagement, not just in Nigeria, but across Africa. So Africa currently has about a $66 billion funding gap. Nigeria has a funding gap of about $712 billion annually. So just to echo on his point, if our current budget is about roughly about 92 billion, including the basic healthcare provision fund, you still have a gap. Just do 712 minus 92.
Okay.
So it tells you why the private sector has to get more involved. Then if you also add the fact that we can't really fund more than or raise enough revenue to even fund our entire budgets, we're roughly about 50%. It tells you why the private sector has to get more involved. So what we have done with the private sector, Corporate Council Africa, is that through our partners, we've been able to figure out how do we align ourselves together to really drive the universal health coverage initiative. So going down to the last mile. So I'll give you a good example. There's a company called Phyllis Pharmaceuticals. Now they're focused on last mile distribution. Now you hear this where people say we do last mile distribution all the time, but they're actually working with companies like Red Star. Then they also have people in those particular localities to make sure it actually gets to the person. So one is to have the Red Star gets there with the particular commodities, but actually make sure that it actually gets there and is used and is monitored. Okay. Then you also have companies like Johnson & Johnson. So Johnson & Johnson is also giving out like antiretrovirals to, in cases happening in Cameroon and Ethiopia. They're trying to work on it in Nigeria, where children that are born with HIV would get antiretrovirals up to 20 years old. And this is currently happening in Cameroon and Ethiopia. So we're just waiting for the Nigerian government to just sign it, and then that will be done. So the bottom line is that the private sector has the capital. The private sector sees what's going on because they are affected by everything. I mean, we're all part of this system. If I were to do a survey here and say, okay, how many people here have national health insurance? Please raise up your hand. NHIS, raise up your hand. Okay. Or you utilize it. Okay, how many people have insurance here? Please raise up your hands. Now look at everybody else in the room. So what's going on? It tells you why the private sector needs to get more involved. There are very few people here that have insurance. So this is Abuja as in the city. Let's go down to the villages. So this is the reason why we're trying to get more involved.
Okay, thank you so much. Dr. Joe, I think, your position, working with WHO is a very important one because WHO supports, several countries. How is WHO leveraging on the private sector to improve health financing in the country?
Okay, just to say that WHO, as part of our normative role, started an initiative about 3 years ago, which we call the Quality, Equity, and Dignity. And is to bring on board the discourse around quality, which is one of the major pillars of universal health coverage. And in Nigeria is one of the 10 first-wave countries that have been implementing that. Our focus generally has been in the public sector. I must be very honest with you. Okay. Most of our documents relate to the public sector. But just to start by a personal experience, when we had a policy dialogue in FCT to introduce quality of care, maternal and newborn quality of care, we invited the Guild of Medical Directors and the Association of General Medical Practitioners. And it was more like an accusation from government side to the private sector. Most of the on-boot cases, most of the bad patients that we have in the public health sector that result into the maternal and newborn mortality that we have, most of them are coming from the private sector. Because largely our private sector seems not to be well regulated. And for me, talking about private sector for maternal newborn, I'm looking at the people, the organizations involved in provision of care around the perinatal period. So the maternity homes, the private health facility. So what WHO is doing right now, through the support of MSD for Mothers, is to scope, to really understand what is out there. We know it's a different ball game with the private sector, especially the private health facilities. What does quality mean to them? Okay. What can we do apart from the obvious ones, accreditation, inspection, and things like that? How do we get them involved? How can we help them to improve quality by themselves in a way that is not costly to them, that makes business sense to them, and the government can also regulate the quality of services they're providing to the populace. So that's what we are doing right now.
The data that I reeled out before we started, looking at now where the money is available to fund healthcare and by extension improve the quality of maternal care. How can we leverage on that availability? Because the money is within the country. People are already spending that money for substandard care, if you like. How can we leverage on that to provide, better quality maternal and newborn care?
Thanks. I think that's a great question. And I think for me it's the core of why I'm here. For those in the room who have been in the development space, particular MNH for decades, we've been saying the same thing for like 2 decades right now. And even Dr. Neka rightly said, as a country, we're not where we need to be. If we take a poll around the room of what the list of high-impact, life-saving interventions are in this country, most people know our issue is the how. Is the delivery mechanisms and the how of doing things. And therefore, no matter how much money is available by whichever donor, the important thing is for us to look at what has worked. What we've been doing for 2 decades, has it worked? If it hasn't worked, can we please, that's because we keep talking of data, but when we generate it, do we look at it and say, this has worked, this has not worked. Let's drop what has not worked and let's pick up what has worked. And then when it has worked, let's not just do it in 1 or 2 states. Let's scale it up across the states. We have isolated pieces of stellar and exemplar projects. How can we bring it together and scale it up? And therefore, quickly, I want to reel out 5 interventions around quality of services that have proven to work. Number 1 is accreditation. And we heard this yesterday. Yeah. We heard someone from HEFMA in Lagos, the Lagos State Health Accreditation Agency, speak about it. It works. It's proven. It works. There are some challenges, and I will mention that. The second one is continuous clinical quality insurance or quality collaboratives. It's proven to work. Okay. The other one is training and supervision, supportive supervision, which also is relevant for the CHIPS, community influencers in country. It works. The fourth one is the use of checklists. It works. The fifth one is performance-based financing. These 5 interventions work, and they've been applied in so many different contexts in Nigeria. In the places where the studies were carried, let me mention some examples of failures or where things can improve. For the accreditation, for example, in Zambia, the Ministry of Zambia rolled out a comprehensive accreditation process for facilities in the country. It was funded by USAID. It was successful. It improved compliance with standards and, aspirations to improve. However, it was expensive. The logistics, it was a nightmare logistics-wise. And so it was cancelled. And so when I heard the lady from Lagos State speaking yesterday saying financing is an issue, I said, there you go. This is experience, is documented. And therefore, what is the learning for us? If we must use, we need to be very targeted on what we want to accredit and leverage on private sector while we're here. So we heard Dr. Lawal yesterday speak about what they're doing with the Society for Quality Health. That is how to leverage private health sector. The government doesn't have to do it alone. They can work with the private sector to say, you accredit, we will endorse, which is why I asked the question yesterday, is their group endorsed by government or affiliated to government? It's not about governments being with them every day, hand-holding, but if they can do that, then the facilities pay them, but the government endorses. Then the government doesn't have to incur all those costs. That's collaboration. In Liberia, you know, the post-war Liberia was 14 years. Liberia conducted a baseline assessment for quality improvements. And what they did, they didn't have the money to go back to now to scope how the quality improvement had taken care. But in the baseline assessments, they saw that laboratory function was zilch, it was zero. That at least incentivized them to buy laboratory equipment. So there's information that accreditation works. Let me quickly speak about continuous quality improvement because I won't be able to speak about others in detail. We actually have partners in this room who are implementing quality collaboratives. I see Pishan is there doing that in Lagos. I know Farm Access is doing part of this in Lagos. It works, it's documented. How much can we scale this out? I visited, private hospitals and public facilities on my last trip with Pishan in Lagos, and I was awed to go to, a very high volume facility in Ikeja. And what they did was to set out a goal as part of their improvements to reduce client waiting time from 1.5 hours to 45 minutes in 4 months. Okay. That was huge because for private facilities, they want to make money, right? That's a critical, the Igbo man, right?
Yeah,
you want to make money.
Absolutely.
So for them, it was huge. It was being real to what their calling was. But at the same time, they wanted patient satisfaction. So they went through a process. They had a QI team. They came up, identified the causes, the root causes. To cut a long story short, 4 months after they had reduced, that was from April to July, they had reduced it to 1 hour, 60 minutes. That's improvement. What did they do? They had a QI team in place, discussed what they needed to do. Some of the things they did was to redistribute their staff within the facilities to GOPD because they were targeting GOPD. And then also reject their shifting schedules. And then what was the third thing they did? I've forgotten what they did, but they had a list of what they did. And they tracked the time series and showed improvements. That's a private facility. I also visited a public facility in Agege local government area who did the same thing. They used checklists and a clumsier checklist. So these are proven interventions. You can have, I've learned that you can have all the money in the world from donors, from government, out of pocket. If it is wrongly used, you will get nothing. And maybe that's part of why 3 decades after, we're still where we are. Thank you.
Okay. In what ways is Access Bank working with the private sector to improve quality of maternal health care?
Okay, so for us, I like to say we have bias for women in my organization, and we reflect it in all the things that we do. Okay. So what we do basically is we collaborate with the hospitals, and then we collaborate with the individuals. And how do we do this? So we provide financing. We might not be able to give the details of what exactly is happening, but what we know is that there's a financing gap for both the hospitals and for the individuals. So take, for instance, in 2015, we developed an initiative called the W Initiative, and then we started with the Maternal Health Service Support Scheme, which is a one-of-a-kind financing for women in Nigeria. Yeah. The truth of the matter is, quality healthcare is expensive, right? And it's even more expensive for women. So we worked with our hospitals. We started with the fertility hospitals and said, you know what? What exactly is the problem here? Why are these things happening? And the feedback we got is that, you know what? These women come to the hospitals. They want to do an IVF session, for instance. It costs about 1.5 million naira. They do it. Unfortunately, these things don't work at the first time. So what happens? The woman needs to go back and get more money. Going back might mean she needs to save for another 6 months, 1 year, to make that 1.5 to come back for the treatment. Unfortunately, like I would say again, the earlier you do this thing in succession, the easier it is for you to, the easier it is for you to give birth. So what do we do? These people can actually pay this money over a period of time, but they don't have this money as at now. What can we do? So we stand in and we say, you know what, we're a bank. Let's take this off you. You go for your treatment. If you meet our criteria, you go for your treatment. You pay us over a period of 2 to 3 years. We can finance it up to 3 cycles. So a situation whereby first cycle doesn't work, second cycle can work, or third cycle can work. We finance you up to those 3 cycles, and we say, you know what, go and have your baby while you pay us over time, which is fantastic. And we've seen people take it from time to time. We've had success stories about this. We've had babies being given birth to for this. And by extension, we increased it to other specialized procedures for women. So it's not just infertility and natal support. It has to do with anything that has to do with the woman. I need to wear glasses. I need to do my braces. It's quite expensive. I know that I can go to an organization, right? And then they would stand in the gap for me while I go back to pay for these things. So that's one of the way we're supporting individuals in it. And when it comes to businesses, earlier this year, we had a partnership with GE to say, you know what? Hospitals are coming back with this feedback that we are intellectual, we know exactly what to do. But you know what? People are going outside the country for this healthcare treatment because we really do not have the facilities, right? And that's our business of doing things. So we're a bank, we're like, you know what? We'll go into this collaboration with you, which we have done, and we say that our hospitals can go to GE, pick your equipment, or any other financing, any other equipment purchasing organizations that you can go to. Pick your equipment and pay us over time. Because the ultimate for us is that quality healthcare, we need to ensure that it's something that we do in a sustainable manner. So we're saying we're going to go for this. And what we realized from the maternal health that we talked about is that I mentioned earlier is that the response has been overwhelming, right? And then you see that even hospitals are saying, my customers do not need to go back and go and save up for more money. Because what it also means that these women are going back, they're being turned down by the hospital, they're not getting the treatment that they want. The hospital too is not making money. And at a point in time, even doctors were beginning to act as doctors, bankers for these women. Because they're like, you know what, you're my customer, you've done this thing twice. So what I can do is pay 50% and then over time pay the rest. So what happens? There's a cash flow gap for these hospitals. They are probably using their working capital to ensure that another woman, a reverend customer, right, gets the treatment that she wants. But that is not their job. Okay. That's the job of a financial institution. And unfortunately, we realize that not many financial organizations are taking that step because the maternal health service support scheme that we launched is just Access Bank in Africa that is doing it. So we need more private sectors to see that, you know what, this healthcare, let's see what we can do about it. Also, one of the things that we do is we are into a lot of capacity building sessions because, like I mentioned, we have a bias for women. We have the W initiative centered around women. And what we also teach is financial literacy because we've also come to realize that, and I'll be very plain about it, you probably knew you were pregnant at month 1 or month 2, right? And then pregnancy is not something that falls on people. It's something that goes for a period of 9 months on the average. So you have a minimum of 7 months to cater to some basic needs. So at that point, we are telling that women, you know what, start having this savings plan towards your child that you're expecting. So it's not about, just having the baby. It's about, as I'm preparing for this baby, as I'm going through the natal care that I need, I also have financial plans for this child, just in case there's any emergency, just in case there's need for me to, pay 5,000 naira for something. I already know that from month 1 that I have this child, I have a financial partner that is telling me that let's grow these things together. So those are some of the ways by which we collaborate.
Okay, thank you so much. Olamide, I know that Farmer Access Foundation, working with private sector to improve quality of care across the country. So just share with us one example, especially that has to do with maternal care, in which Farmer Access Foundation has worked with the private sector, to improve quality of care.
Okay. Before I share that example with you, there was something that you asked, which was very pertinent, in that there's a lot of money floating in the private sector, and how can we harness that money? Because that is the way of the future. And that is what is going to solve all our health financing issues. And I'll give you a very quick example of what a country did. And that country, for me, is Thailand. And Thailand is a country that has been used as an example for a lot of countries that are looking at achieving universal healthcare coverage for developing countries because of their per capita spending on healthcare when they started developing their systems. And I think their per capita spending was about $300 and something. But they did 4 things. The first thing they did was that they developed a strategy to improve their primary healthcare system, both in public and private. Because you see, there's a temptation to say that if we want to harness this funding available in the private sector, then let's start pushing for health insurance. But the problem with that is that when you push for health insurance and people do contribute and they go to facilities to access care and they do not get quality care, then they do not come back to pay. So you first of all need to give them an incentive to ensure that when they pay and they go to a facility, then they get quality health care. So there was a huge investment in primary health care services. Then they now went to a mandatory health insurance scheme and enforced that everyone should contribute to a single pool. The next interesting thing that Thailand did was that they then said that, they moved all their funding as a country to demand side, saying that they would facilitate people to access care from both public and private facilities. And so that created competition and increased the quality of healthcare and also improved efficiencies, right? And then the final thing they did was they then gradually increased their budgetary allocation. And in a couple of years, they achieved universal healthcare coverage. So the question is not for us to see how we work in silos, but to have a strategic plan to ensure that when we do begin to look at this journey of UHC, then we can, harness this money. So going to your question now that you've asked, I'll just give you a story. And again, it relates to this access to finance scheme. And this story is about Caroline. Caroline is not her real name, but it's a true story. Caroline woke up in the morning one day and realized she had low abdominal pain, right? And, she complained, talked to her husband. One of the facilities that we had just renovated had been lying there for about 14 years before we handed it to a private sector. That facility was built with 300 million naira by an oil company. And the moment it was built, it was abandoned. It had generators, it had everything. But for 13 years, nobody accessed it. This woman woke up in the morning, started feeling pains. She tried to take her traditional medicine. It didn't work. They advised her to go to the clinic. And she's like, why would I go to a clinic? Because I've been treating myself since I was born, right? So there's no need for me to go to this white man's medicine. But of course, as the ailment got worse, she decided to go. Fast forward, a diagnosis of a ruptured ectopic pregnancy was made. And immediately, she was operated upon. The reason why she was operated upon was because she was also enrolled as an indigent under the Delta State Contributory Health Commission scheme, right? So what I'm trying to say here is that the reason why Caroline is alive today is not just because of the ability to pay. It was also the availability of the service at the right quality of standard. And that is what we do at Farm Access, looking at a holistic approach to solving issues rather than looking at it in silos.
All right, excellent. Thank you very much. Isiche.
I think it brings a good point. The fact is that, at the moment we have a lot of PHCs that are either inoperable or they're not up to standard, which is a scary thing. But I would like to use an example from TCI. It's called the Challenge Initiative, and it's under the body of NURI, led by a great person called Dr. Moji Odeku, who's somewhere sitting down there. But the whole idea is that there are needs in the states. So first of all, every state says they want to spend money on health. Well, as you know, they don't have enough money to spend. When you look at our statistics, we're growing at about 1.9% in terms of our growth rates, productivity rates. But our population growth rate is 3%. So we're churning out more babies than we're actually producing things, which tells you that in the future, our social amenities like our PHCs will face a lot of pressure. So the question is, are we prepared for that? So now, so what TCI did is that they said, you know what? They put out an RFI and an RFP to several states in Nigeria on, let's start with family planning. And each state was supposed to respond, telling them what they're currently doing around some efforts around family planning, some data around that, and if they would like to be part of this initiative, some level of counterpart funding. So the way the model works is that the states will bring maybe 25%, TCI will bring 75% of capital. The following year, if the states decide to reduce it, TCI will reduce their commitment too. So if the states, so TCI will do what they call a 3-to-1 model. So bring 3 times whatever you bring in.
Yeah.
The following year, they'll do 2-to-1. Then it obviously comes to 1-to-1, and that's it. So that's the model they've been rolling out, and they're currently doing that in 15 states.
Okay.
So that's one way they have looked at how do they manage this thing called financing. Okay. Secondly, I'll use another example for a company called Zipline. Zipline, I remember speaking to Zipline, and they tried to come to Nigeria, and they said, Office of the NSA has issues with drones flying across Nigeria. So while that was happening, they went to Rwanda. Rwanda gave them approval. So right now, between Ghana and Rwanda have given them approval. So now they have access to 13 million people. That means that if anybody needs blood in rural areas or needs an immunization kit in rural areas, the drone will pick it up from whether it's a city like this and move to that particular area there. So this is one way they have worked around it in terms of helping the government not really spend too much money, but also saving them money at the same time. So the TCI model in terms of, is also, another thing I forgot to mention is that through that TCI model, the states have come up with different work plans. Because what you find a lot of times is that when you go to the state, they may not have a really good work plan. So they can't clearly articulate where they need money or where they're going to spend the money because they don't have information around data, around other factors. So what they have done is to work with each state to come up with an actual annual working plan. And then with that, build out a 5-year plan. So regardless of whether TCI is there or not, other partners can come in and the state clearly says, this is our plan. And these are areas where we need help. And this is based on our data, this is what's happening also.
So, Dr. Ojo?
I think I just want to add to what other people have said. There's so much opportunities in the private sector. We cannot overemphasize that. But I feel that government has not really harnessed that. And that's what we should advocate for. Okay. People are already paying for these services. And if we're going to reach universal health coverage, like we talk about, people will still go to the private sector to receive services. So how do we ensure that the services that are being provided, because there's this general perception that if you go to a private sector, the short waiting time, you see the doctor and things like that, the perception that you're getting quality. But if you work in teaching hospital, you see a lot of damage that are being done by the private sector. So that regulation, but not just regulation to kill the private sector, but to facilitate, to make them understand their benefits, their mutual benefit. When you give quality to patients, they come back. They become your champion. They talk to other people. The same message we're preaching in the public sector. In our PhDs, when you provide quality services, that one woman will go to other women in their groups, and when they talk in the evening and things like that. So there's so much that government can promote in that area. So WHO has these 8 standards of care, because there's different definitions of what quality is all about. Yeah. So one of them is to provide evidence-based services. And I like what she talked about, those 5 areas. But more than that are listed in this document called National Quality Policy and Strategy. Nigeria doesn't have that. And we need to have a very inclusive policy and strategy on quality that talks about what happens in the private sector, up to PPMVs that we have. We need to have that. One other area that I've seen pilot programs or operational research is our referral system. I like what you talked about, the drone to provide services. But one of the delays that we commonly talk about is the delay in getting to the health facility itself. And we've seen pilot studies using AURTW and things like that. But we can also have If we can have Uber to take us around, we can have Uber ambulance,
Absolutely.
Those are ideas that I think private sector, we need to encourage them to take. And government needs to facilitate that. Sometimes with money, providing, low interest rates loans for them to start up. There's so many innovative ideas, but most of them will never make it to large-scale implementation because we don't have the resources. I mean, Access Bank is doing a lot, but I don't know if you'll be able to give an entrepreneur, innovator, less than 20% interest rate loan. So that's where government will come in.
Yeah.
We have that for agricultural sector. We have it for hairline. We have it for everything. In health also, we need those. I know Bank of Industry is doing something, but then we need to harvest those innovations and then put them to scale to help us in Nigeria.
I was happy to hear about the development finance institutions Farm Access has approached. The issue for me is the affordability in communities. So it's good to hear about states that are actually bringing out their money to support private sector in terms of providing health services. But are there other financing mechanisms that Farm Access has looked at in terms of sustainability going forward, maybe community-based health insurance, just to shed more light on some of the thought processes that have gone on with Farm Access, going to, in terms of providing affordable health services to the communities in those states where perhaps the governments are not ready to bring out that kind of funding to support the private sector.
So my question then, and I think a comment was made about the fact that a lot of funding is wrongly used. So I'd like a lot of donor funding specifically is wrongly used. So I'd like to just put to the panel: is there a way for for donors to actually optimize your funding and rethink some of how you are funding people out there as well, so that we can get more in the workplace to have greater impact? That's all.
We know that majority of our people usually seek healthcare first in the community pharmacies close to them, and then the chemist and all that. So I heard when the lady from Access Bank was talking about what the bank does by way of equipment provision for hospital, they pay with that by a certain period of time and all that. Those of us that are pharmacists, we know that it's quite capital intensive to set up one. So I want to directly ask the Access Bank people, are they doing anything towards empowerment of pharmacists so that we can set up those community pharmacies close to our people so that they can access care and probably improve the quality of healthcare services?
Speaking from a donor perspective, a lot of the obstacles that we face are the huge transaction costs in trying to fund some of this work, especially younger, nascent businesses that don't have a track history and actually don't have an absorptive capacity for a lot of money. And so what I would actually love for all of you to try and figure out is there an intermediary, platform, institution, organization that you can work to create? I see people laughing. That allows donor funding to be blended with private capital to even reduce those interest rates even more, reduce burden of transaction, link information around the social enterprises with what the investors are looking for, because different investors have different priorities, and allow for the right amount and the right type of capital to support multiple small and medium enterprises, and do it in a way that allows for cross-border capital flows, because that is also a barrier. Have insurance there, that's a barrier. Yep. And also provide potential services to these organizations where you are actually helping to spread some of those overhead and indirect cost, again, creating economies of scale. So if that is a huge need in the market.
Thank you very much for the question that you asked. And in fact, when we talk about financing options for healthcare, we look at it on both the demand and supply side. And so the one I talked about with the Bank of Industry is on the supply side. On the demand side, which is what I think that you're talking about, of course, you know that Farm Access was, in fact, the pioneer of a community-based health insurance scheme, the work that we did in Kwara. And there was a lot of lessons that we took away from that, you know, in terms of things that are required to be able to scale this up and also to ensure the sustainability. There's an economist called Fuchs, and Fuchs said something. He said, to set up a health financing mechanism without compulsion and subsidization is not just only a cruel hoax to the majority of people that cannot pay, but also it promotes huge inequities. So basically what he's trying to say is that, you know, there's a need, when you look at the CBHIS, most of the time they're voluntary. The people that are paying into a CBHIS are unable to pay the adequate amount of monies that will be required to cover them when they need it. And most importantly, they're not really backed by law, and there is no subsidization for those that cannot pay. So as Farm Access, our intervention moved to supporting states to set up health insurance schemes. Not because we want the states to fund it fully, but we want some commitment in terms of legislation to ensure that those that can pay do pay into that pool. The second thing is that we wanted some commitments from states to set aside funding for those that cannot pay, to pay for them. Because, you know, if you make a health insurance scheme mandatory, then what do you do to someone that cannot pay? Do you penalize him? No. If you are able to identify that he truly cannot pay, then he goes into some form of social protection net that allows him to also access service. Now, the last thing that, sorry, I missed it out in CBHIS, is also the fragmentation of risk pools. Because when you have several CBHISs set up everywhere, you have risk pools that are really small and they are not strengthened enough. But when you have a state health insurance scheme that is viable, you strengthen that pool, and that pool can then take on so much more. But in our journey, one of the things that we also realized is that even though governments did do these things, they passed legislation, they made commitments, but you know, you look at state health insurance schemes, only 33% of states have passed their laws. Only about 6 have started enrollments. They also do not have monies to operationalize and pay for those that cannot pay. So we as Farm Access started looking at other alternatives. So one of the things that we did was through one of our platforms called Health Connect, we started looking at how can we channel some funding from remittances outside of the country into the country to pay for healthcare. So there are a lot of people that are sending in monies to people, especially for, and we did a survey, majority of it was for health. So what if these people had the opportunity to pay their premiums regularly and reduce the amount of monies that they needed to do that? Another thing that we started looking at is a financial inclusion strategy. Because you see, it's not that people cannot pay for healthcare. It's that they do not save for healthcare, and they do not save, period. So if there's a way for us to be able to ensure that people are able to put monies aside, even the lowest ebbs of the society, then they may be able to build up enough capital to also get into the scheme and reduce the burden on government to be able to subsidize them. So those are some of the few ways that we're looking at in trying to increase that pool. Because you see, to set up a health insurance scheme is not going to be by book. It has to come from innovation. We have to think. We're not just going to sit down and write laws and say, yes, it must go there. Mm-hmm. People need to sit down and say, look, how are we going to solve this problem? And that's one of the things that we're trying to do through innovations. In optimizing donor funding, I think a lot of donors have, and I do support that to a certain extent, focused on some particular aspects of healthcare systems. You know, you have a particular organization focused on HIV, another one focused on maternal, you know, and that creates what we refer to as a dispersed form of health planning. But what that does is that it creates gaps, and it also creates overlaps in delivery of services. And a particular aspect that donors don't really look at is how do we fund advocacy efforts to speak to governments and create a platform where the private sector can effectively engage with government and influence the policies and make it easier. So, for example, you talked about the zipline thing. flying over. It's policy that would influence that. If you are able to create an advocacy policy to a government to say, look, this is for this, and these are the things that will happen, then the government might be able to do that, and that will open that space for the government. So it's looking at donors also championing advocacy efforts to create platforms where the private sector can effectively engage governments and influence policy direction for that to happen. Then the last thing Marianne talked about in form of transaction costs. One of the things that we realized when we worked with the Bank of Industry was they told me specifically, they said, Dr. Kulaja, it cost me the same amount of money to disburse a 2.5 billion naira loan and a 10 million naira loan. So why would I disburse a 10 million naira loan? Again, most of these loans require what they call an APG, an advance payment guarantee, which you will get from a commercial bank at a rate that, one, you cannot afford, but you must also have the equivalent amount of that money in your bank account. Of course, making it difficult. So we started thinking, how can we solve this problem? So we created a platform and said we will aggregate providers all together. And we as Farm Access will work with these providers and present them to the Bank of Industry and sort of like create some partial guarantees to the Bank of Industry to say, if these guys don't repay back your loan, then we will pay it on their behalf. And because of that, over the last couple of weeks, Bank of Industry has disbursed over $1 million to revitalize 25 facilities.
I was tempted to already say how many folks on the panel and in the audience are actually funded from the foundation, but that is not our model. But we fund global levers. Since the question has come up, the foundation is a major funder of the Global Fund. Okay. And it's a recognition of that principle, that there are certain global levers where you can do more by funding them than doing it on your own. The foundation is a major funder of Gavi. And you know the role of Gavi in many countries around vaccine. Yeah. That's an example. Mm-hmm. We're actually in discussions from the Nigeria office to also fund a regional body for several reasons. So we recognize the role of levers at global, regional, and even country level. Right now, we're working on an investment for a national lever. We call it the TA Hub, Technical Assistance Hub. And it's going to do exactly the same thing. Rather than have transactional costs for one investment that costs, 2 million, why not have a hub that can manage bigger sums of investments and make those investments more cohesive across a larger geographical area? So we are thinking through this, and it's important. Can I use the opportunity to speak about other mechanisms? For example, the foundation has what we call, MOUs with government. Okay. This recognizes that you don't want to impose your own interest on government. And so with about 6 to 8 governments in this country, we have MOUs. What happens is that within the MOU, to cut 2-minute summary, the government, we agree around the AOP. Someone mentioned the plan. So the MOU is built on the state's annual operational plan, okay, not the foundation's plan. And then within that MOU, typically over 4 or 5 years, it encourages the government to put down a set and agreed amount at the beginning of every year, and the foundation matches that amount. So they use it for what they want to do, and some of the partners working in those states are probably familiar with that. In one of the states, the government has now moved from 0 funding for routine immunization to 100% over a 5-year period. Okay. Because of that, because they used to put in 0 for RI. Mm-hmm. And this is a state with one of the largest populations in the country. The foundation started with 100. And we did this in partnership with Aliko Dangote Foundation, I must say. Second year, we recalibrated. Now they're doing 100% of that funding. So these are ways of incentivizing governments to spend money where they should spend. The last thing I will say quickly around a question around, so what is of interest to the foundation? For example, I speak for the foundation. Yeah. Increasingly, the interest is what the government's interest is. Can I see by a show of hands how many people have seen the national RMNCH quality of care strategy? Great. So when I read the summary from the last National Council of Health that held recently, I saw one of the, the consensus points or resolutions that we should all align with the national quality. And I went to the MOU, Ministry of Health. Where is this document? I have never seen it. I searched online, didn't see it. So the point to be made is that we are all different entities trying to do good. Ultimately, our intent is good. But the framework, policies, strategies are what brings us together around a common consensus set by government. Sometimes the policy is outdated, is old, it doesn't work, but it's the learnings from our programming that should influence how these policies, evolve. So take some of these policies and say, of this is what we want to do to contribute to this. Okay. Let me end by saying that an example of leaning into government policy, if you are in a state, is being a member or engaging actively with governance structures. I was in a CSO meeting 2 days ago in Kaduna, and there was this lady who was very, very vocal and dramatic about, the government doesn't do this, we do this. So we asked all those in the room, can you please mention which technical working group of government you belong as part of your work? And she said something. Everybody said, no, that's not the TWG. She said another thing, that's not the TWG. So she didn't even understand which governance structure at state level she was supposed to align with. So how do you embed the work you're doing? Okay. And then when you leave, it all falls apart.
Okay, thank you very much.
All right, thank you. So, Doctor, let me just bust your bubble. You can actually get loans that are below 20% in Access Bank when it comes to health. I just thought to put that out there. So we have like I said, we have the maternal health service support, which is particular for women in health, right? And that is way below the 20%. And then for talking to you about the community pharmacy, so I remember that I think I need to change a perception, right? The banks make money by giving loans. The problem is that banks want to know how they are going to get their money back. And as far as somebody can prove to me that, you know what, I'm giving you this money. I'm a bank. I also don't own the money. It's other people's money. If you can tell me that I am going to give you back your money, I want to make profit, so I'll give you the money. So coming to that, I remember like some 2 years ago, we were even having discussion with ALPS, of Association of Lady Pharmacists in Nigeria, to see how we can grow that sector. And of course, we'll be coming up with, so many of them have been accessing finance from us. So I think I just put it there that the banks are in the business of making money. It's just prove to us that we're going to get our monies back, and we'll do that. And in addition to, when it comes to, we're big on sustainability, and as a bank, right, we're not so in-depth into the whole giving donors and everything. But what we've also done is that we've launched the ACT Foundation, which handles that arm of when it comes to healthcare, donation, giving grants. We have that foundation set up by Access Bank to say that, you know what, we have a sustainability team inside, but we're going to ensure that that ACT Foundation serves the public, is into all, every discussion around health, education for the public. So that is our way of doing it, because we are not champions at the game. We are bankers, we are financial services providers. However, what we can do is we can put our money behind someone that is doing it to ensure that they do a very good job.
Thank you very much, Dr. Ojo.
Thank you for your point. I'm very happy to note that we have under 10% interest rate.
It's still under 20. It could be like 19.5.
No.
But it's still under 20.
You can get for 14, actually.
15?
14.
14. Okay.
14.
Yeah.
Okay.
Yeah.
Okay, so just say that I want to comment on the point, and just taking up from where she talked about health. We also need to understand this. There's the business side of health. And we've been hearing donors. We have a lot of donor funding over time. We need to change that perception. They are partners. They have a theory of change behind them over time. When they give money, they are also expecting some things to change. Yeah. And if we cannot demonstrate to them, sometimes we talk about health that you should know is good for you, talk to donors that way. But donors are also looking at the end of the day, what are the numbers for me? What are the return on investment? And that's something I think we need to preach to banking sector, to other areas, there's return, there's money. It might not be immediate, it might be long term. This is where government needs to come in with big donors who can put money in a pot. And I'm very happy that the bank, I think people from World Bank are here. Okay. There are opportunities from them. There are things we can make investment case, even for private health sector, where we can give very low interest. I mean, when I'm talking low interest, I'm talking 2%, I'm talking 3%, that is sustainable for business. They can, pay back over time. I know we don't have that in Nigeria right now. But we need that. We need for our pharmacy. And when we have this investment, we can easily request for quality from them. Because I've tried to run a private health hospital before. It's shut down within 1 year. It's not easy. If you're not going to cut down on gloves, on spirit, on cotton wool, then you're not ready. I'm telling you, you cannot break even and get the right quality of people. I can't even employ a full nurse. It's very costly. And those are areas government needs to come in, number one, to ensure there's quality, and also to facilitate by providing these low interest rates. And that's in the interest of the donors, is in the interest of the private finance institutions, is in interest of everybody. And that's just my advocacy.
Okay, thank you very much.
I think one of the things to keep in mind is that you always have to look at the fiscal and monetary policies of every government.
Yeah.
Very, very important. On September, I think it was the 23rd, we hosted 10 ministers of health across Africa. And one of the strongest things that we observed is the fact that those policies that moved pretty far or helped out in terms of economic growth were backed by law. So that's number one. Number two, if you're going to try to advocate for anything around policies or improvements in terms of tying things to economic growth and development, especially around maternal care, you need to understand, you need to have a seat at the table. Somebody mentioned it earlier. We are on 3 committees. We're on the National Council on ICT, we're in the Reproductive Health Working Group, and then we're in the National Assembly Private Sector Business Roundtable. And even within that roundtable, we're in 3 areas. So the bottom line is that you can't talk about you want to do this or that or make an emotional appeal if you're not sitting at the table. That's the second thing. The third thing is the fact that we do have donor working groups. There are donor working groups around human capital. There are donor working groups around other areas. I'm not too sure if there are donor working groups around health in particular. Yeah. But then one could be established where they actually have access to state and federal governments. And they actually have consistent meetings with them in terms of how they can move things forward. Somebody asked about transactional costs. One of the things about transactional costs is the fact that we see a lot of times is that somebody may want to give funding to maybe partner up with another local private sector organization, maybe bring in capital. They have capital as a big organization, but they want to give to a local entity. But they find out that within that company, director is father, the mother, the children, their brother, their sister, this and that. And to them, it's okay. But to the fund, they're not going to give you any capital because your corporate governance structure does not show any sustainability.
Exactly.
So if the father or mother dies, then what happens to the rest of the business? And that's what you find out a lot of times when you see hospitals that this doctor owns. All of a sudden, the doctor dies and the hospital goes down. So nobody's going to infuse capital into your business when they see that. So going back to the last point around that synergy, you find out when there's a lot more synergy within more partners coming on the table, it tends to lower the cost of doing business and cost of financing. We're having a chuckle here, laughing about something, but to me, Sterling Bank is doing more than Access Bank around health. They've decided to key more into the. I'm not a Sterling Bank. I bank with Access Bank, but anyway. but I'm just saying that Sterling Bank is doing more around health, and so the radiology in the radiology department you have at Luth. The equipment's there. We're financed by Sterling Bank with other partners, not just Sterling Bank alone. So the bottom line is that if you're able to tie whatever you're doing to some sort of economic growth and make even your legislator understand that this is important to you. This will save you money, and this will help even bring more money into the budget. They will understand from that very layman point of view. Because when we go there and talk to them, they say people are speaking too much English. People at a high level, come down to this level. So these are the people you are talking to, and trying to tell them why these things are important. So what I would say is I caution anyone making an emotional appeal about health, go back to the facts and figures and why this thing needs to make more sense. So you have less children, but with less children, you can do more with the capital. You know what I mean? With less children, that means that the health of the mother should be a bit more healthy. She can do more. So these are the basics that we have to use to drive our points across. And then we increase our productivity, and we increase our growth, and we increase our numbers.